I'm going to go ahead. So we'll go ahead and kind of do it very similar to the way we did it during a lot of the interviews. And feel free in the room to shout out questions. I will try and pay attention to the chat. But folks, if you like see questions in the chat, can also yell at me to pay attention. So we're going to start out today with the case of a 40-year-old female coming to the ED with a headache. And I'll let you guys tell me what you want to know. What happens next?
When did it start?
When did it start? Yeah. So it's been going on for 1 week.
Just like constant during that week?
Yeah. She said there was a gradual onset, but now it's continuous.
How does she describe the headache?
Yeah, so she says it's really, it's focused in the back of her head, just a constant dull ache.
Has she had headaches before?
Yeah, she has a history of migraines and tension headaches. But says this is different because of how long it's been going on.
Has she tried anything?
Yeah, so she doesn't have, she has migraines so infrequently that she doesn't have any abortives. Her last was over a year ago, but she's tried Tylenol without any improvement.
Has she had any dizziness or vision changes associated with it?
Yeah, and she says she actually has had, that's another thing, now that you mention it, that makes this headache different from her migraines and her tension headaches in the past, is she does have dizziness, and feels like she has some, she can't tell if it's sensitivity to light or just like she has a headache and she doesn't like bright lights. But she's more sensitive to light than she typically feels with her migraines.
She had a COVID, Johnson.
Yeah, so she was vaccinated with the COVID, the Johnson & Johnson vaccine, 2 weeks ago. Why do you ask?
There's a side effect of dural venous sinus thrombosis.
Yeah. Yeah.
Potentially with it.
Okay.
The thrombotic thrombocytopenia, which is like TF4 mediated.
Awesome. So what do we want to do? Do we want to know any other information? What do we want to do to test for it?
Oh, I guess we're just going.
Or what else do we want to know? What else do we want to know? What other tests are we going to run?
Yeah. She needs a CBC, so you can check the platelets.
Yeah, I think that's a great idea. Anything else in past medical, surgical, family history you guys want to know?
Did she have any other, like, neurological symptoms, any weakness, numbness, tingling?
Yeah. Oh, great question. So she has no focal neurodeficits, numbness, tingling, weakness at all.
Does she have any prior history of clot?
Yeah, no personal or family history of DVT. Yeah, so she is a never smoker. She has like social alcohol use. And no other drugs. And then, what other questions you asked, Andrew? Sorry. Oral contraceptives? No. Her only home medication, in addition to the Tylenol, is famotidine and B12.
Why B12? Take it.
Yeah, she just takes it. And then you do ask her, because on the medication list, there's also augmentin. And, she says she was seen in an urgent care last week for when these symptoms started, because she thought it was sinusitis. And generally, she feels better compared to then, but the headache hasn't gone away. Okay, and let's, but just for the sake of completeness, fevers from Jessica. Yeah, so she doesn't think she had any fevers, but she does have some malaise and arthralgias, myalgias.
Any confusion or her status?
No confusion, no loss of consciousness. And yeah, so, and her vitals, when she comes in, she has a temperature of 35.9. So chilly or just in a cold hospital. Heart rate is 83. Blood pressure is 141/96. She's starting with respiratory of 18, of course, and she's starting 96% on room air. And as we go through the physical exam, anything in particular you guys want to pay attention to?
This is just a series of like evolution.
Yeah, awesome. I think that's super reasonable. And
That's really nice.
just being explicit, why are you wondering about that?
There's like another sex like who would do tumors.
Okay, yeah.
We can all check, we can all see it for Venous,
Yeah.
yes.
Okay, and I'll tell you in general, she is well-developed, well-nourished, and no clear distress, but has her eyes closed and like, was, I guess, tired appearing. She has a normal HENT, her pupils are equal round reactive, but she wants to close her eyes right afterwards. Moist mucous membrane. Posterior oropharynx does have some exudate. And let's see, neck, there's some cervical lymphadenopathy. Other than that, she's got regular rate and rhythm. Pulmonary is clear to auscultation, or with good air movement, we'll say. And abdominal exam non-focal. Neurologically, cranial nerves 2 through 12 are intact. She has normal reflexes and full strength and full sensation in all extremities. Yeah. And then I'll say you ask about, you noticed she has a little bit of marking on her face, and you ask if that's, bruising or has been there for a long time. And she says that she feels like that's new in the last week, and has noticed a couple other places. And I can show you a picture of what that looks like. And they're non-blanchable. So we talked about getting a CBC. Any other initial labs we want to get?
UA, BMP.
Okay. So the BMP and UA are unremarkable.
possible you can zoom in, just a little bit?
On the skin findings?
No, sorry.
Oh, on this.
Yeah,
Let's
sorry, I just
see.
can't read that far.
Yeah, let me see, I can do a different. No, that's not really much better, is it?
Oh, no worries, it's not. Sorry about that.
Oh, no worries.
There you go. Bottom, right?
Yeah, make it like,
Thank you.
Yeah, is that better?
Yeah, thank you
Good,
so much.
okay, yeah, no worries. So, and let's talk as we think about the tests that we want to order, things that are on the differential. So we mentioned the vaccine-associated, thrombotic thrombocytopenia. I'm just gonna say TTS, because that's a lot easier. And then we talked about vasculitis. And any other things we're worried about?
Like a particular migraine or posterior stroke.
I love
It'll be
those.
weird for a week, but
Yeah. They can be missed for a while, and she's just like off classically like posterior stroke drop and like seen once and missed and then might come back later. Perfect. And then what do we think, even though she doesn't have fevers with this like headache, malaise, I think she doesn't have a bacterial meningitis, because she would likely be dead at this point, but I think like aseptic meningitis. Okay, so in order to kind of thoroughly evaluate these, what else should we get?
MRV.
Sorry, what?
Probably an MRV for the.
Okay. Okay. And I'll say, as we are waiting for the imaging to come back, we do get her, blood work, and she's got normal white, 8.1. Hemoglobin is 15, and her platelets are 20.
Smear 'em.
Yeah, you want to smear?
Yeah.
Let's see. Wonder if I put that, I don't think I put this in the right order. No, we get an ECG. It is incredibly unremarkable. But we order the smear. And what are we looking for on the smear? It's really important if you're looking at a smear for thrombocytopenia. Schistocytes, as well as that, yeah, platelet clumping to rule out another cause of like pseudo-thrombocytopenia. Excellent. And as you wait for that, we'll also get some imaging. And platelet count, perfect, yeah. In her case, we get a CTA. So unfortunately, she actually hasn't been seen by her TCP since 2018, but she's always had normal platelets in the past. And she only has like maybe 2 or 3 CBCs in the symptoms, but
Yeah.
enough to think that
They were normal.
yeah, they should be normal. And I'll play this. I know it's fast. And I admittedly went over this with the neuroradiologist and also looked at the key imaging findings and was not able to appreciate, however, there is an occlusive dural venous sinus thrombosis involving the left transverse sigmoid and the visualized internal jugular without any associated infarct. So you guys actually got this pretty quickly, which is what I kind of anticipated, that she does have central venous sinus thrombosis that is most likely associated with the J&J vaccine. We actually had another case along the same timeline, and this with someone who's presented also with the central venous sinus thrombosis and subsegmental TEs, which I don't think we need to go through this CTPE because it's not impressive, other than there's not a ton of, CTPEs, and her lungs are otherwise normal. And then this is the smear that did come back a couple days later with completely normal, no evidence of platelet clumping or schistocytes. So I wanted to talk a little bit about this new, it was called like clinical syndrome X, of thrombotic thrombocytopenic syndrome associated with vaccination. And as Ariana pointed out, it's associated with PS4 antibody activity. And so, as I mentioned, there were 2 cases here, both of which had negative serotonin immunoassays that are run here, but their PS4 ELISAs that are run at an outside lab were positive. And that was actually the case for most of the events seen in the U.S. So I wanted to take a minute, and this is kind of what those results look like when they came back, and it's important that these were strong positives, not just like equivocal. Again, this is a rare adverse event that was initially associated with the Oxford AstraZeneca vaccination in Europe and has now been implicated in several cases in the United States. So again, just some background. In general, cerebral venous sinus thromboses are incredibly rare, but obviously a very serious and potentially life-threatening condition. In Europe, this syndrome was described in association with the AstraZeneca vaccine, which uses a chimpanzee adenovirus vector. The proposed mechanism is similar to HIT in that there's platelet-activating antibodies that develop without exposure to heparin, and they haven't really gotten any further than that as to exactly what causes this. Importantly, the Johnson & Johnson vaccine uses a human adenovirus vector, as opposed to like the mRNA virus vector in the Pfizer and Moderna vaccine. So just to give you a quick rundown of the timeline here, because I do think that that's important as well. On February 27th, the Johnson & Johnson vaccine received emergency authorization use in the United States. And in March 18th, just about 3 weeks later, the EU reported they were noting increased incidence of the thrombosis with thrombocytopenia that seemed to be associated with this Oxford AstraZeneca vaccine. On the 12th, or as of the 12th of April, about 7 million nationwide vaccines have been administered in the United States, and there were 6 cases of these cerebral venous sinus thrombosis at that time, based on the VERIS, or the Vaccine Adverse Event Reporting System. So the next day, the CDC and the FDA recommended a pause in the administration of the Johnson & Johnson vaccine. They reviewed the data and reviewed the adverse events, as well as additional adverse event reports. And 10 days later, they cleared the Johnson & Johnson vaccine for ongoing use in all populations in the United States. However, just I think about last week in JAMA, there was a the U.S. case report of the cerebral venous sinus thrombosis from March 2nd to April 21st. This is, so again, going through this is a new syndrome that's theorized to be, well, is independent and separate from the HIT because it does not involve any exposure to heparin. This QR code will just get you to the website with the Brighton collaboration. It's part of the World Health Organization that helps develop diagnostic criteria. And this is the site where they talk about how they're developing the criteria and the criteria they currently have for TTS, which are pretty simple. They only require 3 conditions: an acute venous or arterial thrombus, new thrombocytopenia with a platelet count less than 150, without evidence of platelet clumping on smear, and absence of prior exposure to heparin. So it's relative compared to a lot of the thrombocytopenic for her is much easier to diagnose. And in this case series looks at the first 12 cases of this TTS that have been validated in the United States. Let's see, going through here, a couple things that are important to note are that the ages were divided just into two categories, 18 to 39 or greater than 40. Everyone was less than 60, but just to provide patient confidentiality, and neither of the cases that we saw here are included in this case series. On average, it took 8 days between vaccination and symptom onset, but the range was 6 to 11 days, and it took at least a week after symptom onset for hospitalization. All 12 of the patients in this case series were hospitalized. One passed away, and I believe 10 were placed in the ICU. Interestingly, going through, it's worth taking a look at this article. They have brief case vignettes for the first 6 cases that were reported prior to that pause by the FDA and CDC, and one case is nearly identical to the patient I presented, even down to the petechia in a similar location. So I think it's a really, I think, impressive clinical syndrome in that to date, the cases are almost identical. And 11 out of the 12 patients presented with headaches. The one that did not just had back pain, bruising, and abdominal pain, and she had a foramen venous thrombosis. And they were all women between 18 and 59 years old. Looking at the serology testing that was done in these patients, again, interestingly, it was almost identical across the board. Everyone had a negative PCR. There was one patient that didn't have the viral assay done, and although it's not described, I suspect it's one of the 3 patients that died in this case series. So, sorry, again, breaking it down, there were 12 patients total, 10 were placed in the ICU, 3 had intraparenchymal hemorrhages, or 7 had intraparenchymal hemorrhages, and 3 of those with intraparenchymal hemorrhage died. They tracked the treatment of the first 6 patients as well, so of all 12 patients, the first 6 actually did receive heparin during the course of their hospitalization because it was not kind of an understood entity at that point. But of the next 6, 2 didn't receive anticoagulation, 2 received bilirubin, and 2 received ergatrovan. In addition to that, of the 12, 7 got IVIG, and 3 got steroids. The 7 that got IVIG all had intraparenchymal hemorrhage, with the exception of the one that passed away. I think too quickly to receive IVIG, steroids, or any anticoagulation. And I suspect that's also the patient that did not have the PF4 ELISA testing done. Because every other patient that had the PF4 testing completed, their ELISA was positive, but in the majority of cases, the serotonin release assay was negative, which again is an interesting assay, or interesting clinical phenomenon that was very similar to what was found with the European population following the Oxford AstraZeneca results. Let's see, and I think there's something other, and then most of the patients also completed a pretty thorough hypercoagulability workup otherwise that returned entirely negative. This is also the case for both of the patients that we saw here, and was similarly the case for the patients in Europe. Looking through the other characteristics of these patients, 7 of them did have, some predisposing conditions that has been associated with increased clotability, 6 of which it was obesity of a BMI greater than 30, and 1 was on OCPs. But it's really a generally healthy population, without any other risk factors. I think the one other thing that's important to note is excluded from this study, there was one patient who had a cerebral venous sinus thrombosis following Johnson & Johnson vaccination, but they were hospitalized with COVID pneumonia. So I think they were really on the outlier of the bell curve, that the vaccination didn't work, and they also had a rare side effect of the vaccination. Associated with this paper, there was a great editorial discussing kind of how to interpret and kind of offer recommendations for our patients based on this data. So importantly, the rate of cerebral venous sinus thrombosis in the women who received this vaccination was 5 per 1 million from the ages of 18 to 50 years old. Typically, it should be 5 per 100 million per month of women in that age group. So it's a significant increase in the rate of cerebral venous sinus thrombosis. But there's a lot of other information missing about these patients beyond really just their age and that they got this vaccine recently, to understand how to better risk stratify the population in general. Again, and the patients were overall very similar to the European patients, which makes the suspected link to adenovirus vector as as a vaccine vector a possible etiology of this, although there's not any clear reason why this should be this would be a result. So then they talk about kind of what should the response of CDC, FDA, and other governing bodies be to these adverse events. And they note, interestingly, around the world, it's already been very varied. Norway and Denmark have said no more Johnson & Johnson vaccine administration to anyone in their population, which might make sense in the context of noting that all of the patients in Europe as well as the US who had this complication were Caucasian, like non-Hispanic Caucasian. And that's the predominance of the population in those two countries. Germany has cleared the Johnson & Johnson vaccine for the population over 60. The UK has cleared it for the population under 30 without pre-existing conditions. I can't say that I understand that one at all. And both the US and Canada have cleared it for all adults. The US has a statement kind of urging caution in women between 18 and 60, and Canada has no statements regarding any populations that should merit additional consideration. The kind of conclusion of the author of the editorial was that, again, like any vaccination is most important, but in the US and other resource plentiful countries where the mRNA vaccine is relatively available, that should be recommended above others. And only in the case where cold chain or allergies to mRNA vaccination components are unavailable should the Johnson & Johnson vaccine be kind of the vaccine of choice. Yeah.
Right, you might have already said this, but what was the time course from when people were vaccinated to when they presented?
Yeah, that's a great question. So it's a kind of it's an interesting time course. So all of the patients experienced symptoms between 6 and 11 days after their vaccination, on average 8 days. But they weren't hospitalized until an average of 7 days after their initial symptoms. So they generally presented and were hospitalized about 2 weeks after their vaccination.
I read it could be up to like 6 weeks too.
Yeah, and that's one of the considerations in the concerns, yeah. And so and that's one thing the author of the editorial touched on, which makes this whole thing incredibly challenging, is as with all clinical syndromes, there's likely a spectrum of presentation. and kind of determining a better way to pick up on the subclinical presentation, to get a better true idea of the incidence and prevalence of this complication is really important. However, that's an incredibly difficult task, because it's a CTA really to even begin to evaluate this. Many people would likely need an MRI, which are not easy or cheap studies to obtain. And even if you're going with screening of people with headaches, as that seems to be the vast majority of presenting symptomology, almost everyone post-vaccination has reported headaches. So it wouldn't narrow the population down. So it's a very interesting question of like, are we just going to be satisfied with finding the women who have severe headaches for a week and present and have this advanced imaging? In the case series that they go through, I think 4 out of the 6 cases had a focal neurologic deficit, generally unilateral weakness or changes to sensation. The one patient that was closest to our, the one that I discussed, had a episode of loss of consciousness. But again, those are probably the most dramatic of the clinical presentations, and there's almost certainly a large number of subclinical presentations that are missed. The question is also like, is there any long-term consequences to a subclinical presentation?
Amelia, on the management of this,
Yeah.
I know since there's like overlap with HIT based on the anti-PF4, the recommendation is like avoiding heparin. Is that the thinking there because like more exposure to heparin on top of whatever is already going on would like rev up that process further? Even if they weren't already going to develop HIT?
This is a really good question. So I looked into if there was like a thought process behind it. And I think the thought process just was like, heparin's in the name of what it's like, so we're going to avoid it.
Fair.
Looking through the series of like the first 6 patients versus the second 6, remembering that the first 6 actually did get heparin because we didn't realize that this was a similar mechanism or seems to be related to HIT in some way. They didn't have like worse clinical outcomes. The patients that we're seeing here both got bilirubin with IVIG and steroids, because that was kind of like the most aggressive therapy offered, and there weren't bad outcomes with that. But I think that's a really good question that no one like, it's more because the name is overlapped, I think, than anything else.
Yeah. It could be just kind of voodoo a little bit, and it's like that avoiding heparin will be like the hydroxychloroquine.
Yeah.
Of this program. Okay.
And I think
Cool.
another important kind of like separate learning point from this was that difference between the heparin PF4 ELISA test and the serotonin release assay, or the like latex and something, I can't remember that name, but the different assays that are used to detect functional HIT antibodies being negative when the ELISA is positive. And there's not an excellent reason for that, other than the serotonin release assays are typically thought to be more sensitive for HIT specifically, and also tend to be run at on-site labs with a wider clinical variability in exactly the reagents used, whereas the ELISA tests tend to be run at one of a few of central laboratories with very similar clinical processing. So it does seem to be specifically antibodies to the PF4 from alpha granules released when platelets are activated, as compared to potentially other mechanisms from HIT. But I think, again, just like always hammering home that even though the tests are technically for the same thing, they're testing slightly different things or in different ways, and that leads to a different result. It was also interesting to me, just the fact that we had 2 cases that are presumed to be this TTS. It was in the clinical timeline, and I don't know, because no one obviously can tell me. There have been a total of, I think, 15 reported and verified now through the vaccine adverse event reporting system. I don't know if these 2 are included in that or not, or if they haven't quite met their validation criteria at the point of publication of this article. But it made me wonder if potentially the prevalence is higher than what's been reported to date.
I think there's 2 in our one hospital, it's hard to imagine it's a 1 in 1.1 million chance.
Yeah,
Yeah.
exactly. I mean, yeah, we do see some rare cases, but, yeah. And great job. You should have been here. Within the first, 5 minutes, we get down to the Johnson vaccine recently.
That's awesome.
Yeah, it was great. I kind of thought they might, but awesome job, guys.